Well, thanks so much for joining me today for episode 13 of season 4 of the Healthy Skeptic MD podcast. I'm Dr. Michael Hockman. I want to again begin by thanking and acknowledging the SCAN Group for funding and supporting the Healthy Skeptic MD. The SCAN Group is the parent organization of Healthcare in Action, the medical group I lead. It's also the parent organization of the SCAN Health Plan, which is California's largest independent nonprofit Medicare Advantage plan. And the views expressed in this podcast are my own and do not represent those of SCAN's. So my guest today is Dr. Maren Batalden. She is a truly terrific doctor. I know that because she was one of the lead attending physicians during my medical training, and to this day I still try to emulate the way she cares for patients. She's got a great bedside manner coupled with a really excellent fund of medical knowledge and very good clinical judgment. She's now also the Chief Quality Officer at the Cambridge Health Alliance, where I did my medical training. It's a large safety net organization in eastern Massachusetts that we'll have a chance to talk a bit about in today's discussion. So Maren's going to tell us about a framework for thinking about the clinician-patient relationship as a partner that co-produces health. And we'll learn today, for example, why incentive programs that incentivize both the clinician and the patient at the same time are much more effective at generating health than programs that focus on either one or the other. So it's a really good discussion. Please do stick around for it. If you find today's episode engaging, please do search and subscribe to the Healthy Skeptic MD wherever you listen to podcasts. Before we jump into today's discussion with Maren, there are two quick health news items I want to touch on. So the first has to do with that mantra that many of us have heard time and again, that once you start a course of antibiotics, you absolutely must complete it so you don't promote resistance and you don't get a recurrent infection. And it turns out that some newer data is actually questioning this mantra. And one of the key experts who is presenting a counter perspective is Dr. Brad Spelberg, whose name you may recognize because he was one of the first guests I've had on the Healthy Skeptic MD. And Brad and some of his colleagues have suggested that there really is no evidence to support those longer 7 to 10 to 14 day standard courses of antibiotics. And in fact, these longer courses may be more likely to promote resistance, not as effective, and of course, much more likely to cause side effects. So Brad and others have said maybe it is okay after the symptoms have improved, that would be an appropriate time to stop antibiotics. So there was an important study this month in JAMA that adds weight to that perspective. It looked at children presenting to emergency rooms in hospitals with pneumonia, and it found that a 3-day course of antibiotics was just as effective as a 7-day course after discharge. Now, I'm not suggesting that anyone disregard your doctor's advice, that you stop antibiotics before your doctor says it's okay. But if you do get one of those 7 to 14 day long prescriptions for antibiotics, it is perfectly fair game to ask your doctor if it really is necessary to be treated that long. And maybe would it be okay if once your symptoms have resolved, or at least have resolved for a day or two, that at that point that you could stop the antibiotics. So the second news item I want to touch on is another JAMA study. This one's looking at cannabis use among pregnant women during the pandemic. And unfortunately, and probably predictably, there has been an increase in cannabis use. So it's gone up from 6.75% to 8.14% among pregnant women right before they deliver. And this is based on toxicology screens of women. So sadly, this is yet more evidence of the impact that the pandemic is having, not just on our physical health, but also our mental health. And so it's really important to have this in perspective when we're setting policies. And we really do have a juggling act to do when setting policies to balance the public health implications of virus spread with the psychological and mental effects that these policies have. So with that, let's jump into our discussion with Dr. Maren Batalden. I'm very happy to be joined today by Dr. Maren Batalden. Welcome to the Healthy Skeptic MD.
Thanks so much for having me, Mike. This is going to be fun.
So, Maren, you and I have known each other for a while. I did my residency training. You were my program director. We won't say how many years ago that is, but a little bit over a decade. And to this day, the Cambridge Health Alliance is my favorite health system I've ever worked in. It is probably the place that I think values patients more than any other health system I've worked in. Could you tell us a little bit about the Cambridge Health Alliance?
Sure. It's so nice to hear that the Cambridge Health Alliance still has a place in your heart after all these years, Mike, and all the places you've gone and the things that you've done. I also feel really just deeply connected to the Cambridge Health Alliance as a place. I love it. And I've been here, as you alluded to, for a long time. I'm going on year 18. So the Cambridge Health Alliance is a integrated public health system that serves 7 communities in Metro Northwest Boston. So it's a network of ambulatory clinics that provide primary and medical and surgical specialty care. It's 3 community hospitals, 2 really busy emergency departments, an urgent care, and a comprehensive set of behavioral health services, mental health, substance use disorder services. And it is unique in a variety of ways. Has very strong identity as a part of the safety net. So about half of our patients are patients that get their care paid for through Medicaid. We have less than a quarter of our patients that have commercial health insurance, and nearly half speak a first language other than English. So it's a very diverse patient population. It's unique in part because of its public health orientation. So the Department of Public Health in the city of Cambridge reports to our CEO, and we have really long-standing and deep connections with town governments, with community and social service agencies. We have school-based clinics and a healthcare for the homeless program, so really deep public health roots. It's also unique because of its commitment to mental health services. So we have as many inpatient medical beds as we have mental health beds, so there's sort of parity there. Just a really big footprint of mental health services. So I think that means that the care that we provide is really, it's really whole person care that values mental health as deeply as it does physical health. And then the last thing that makes it unique is that it's a teaching system. And so, as you mentioned, you did your residency program there. We have relationships with Harvard Medical School and with Tufts Medical School, and lots of nursing training programs and radiology tech training programs. And the fact that it's a learning organization, I think, gives it a spirit of innovation and curiosity that also makes it unique as a community health system.
Well, one thing I didn't realize until after the fact, training there in a community setting, you actually really learn to be a doctor. And a lot of my friends and classmates from medical school trained at big, certainly larger in size academic places that were very focused on specialty quaternary care, but they didn't know how to do the simple things of primary care. So I thought that was a great thing about it. One thing that caught my attention, I didn't realize the statistic was quite so high. Did you say that half of the patients, the primary language is not English?
Yeah, 45% to be specific. So almost half speak a language other than English, which also means that if you're committed to providing care for this kind of diverse patient population, you really have to invest in interpreter services and figuring out how to bridge those gaps.
One of the things I loved about it, the different communities, Haitian Creole, there's a big Brazilian community that's served by the Cambridge Health Alliance, Puerto Rican communities. It's a really fun place to provide care. And I'll just second the emphasis on primary care, integration of mental health services. I just haven't seen it all put together in the same way that CHA has been able to do it.
Yeah, it's a unique place. I feel like it's a great privilege to have been able to make CHA my professional home for so many years.
All right, so let's talk a little bit about your role. You are a hospitalist, meaning you take care of patients in the hospital. Could you tell us a little bit about your clinical work that you do?
Hospitalist medicine is about as old as my career. It's sort of about 20 years old. So I was actually one of the first hospitalists, and in some ways a founding member of the hospitalist program here at CHA, because as I was finishing my own residency, hospitalist medicine was kind of in its infancy or toddlerhood. And it is a kind of specialty that has grown very quickly over the last 2 decades. Once upon a time, I sort of imagine a doctor that Norman Rockwell might have painted. And I think of that as the once upon a time in medicine when a primary care provider would actually see a patient in clinic or maybe even in their home, and then they would follow them into the hospital, and they would see them before the day started or after the day was done, and sort of squeeze in the hospital care around the edges of their ambulatory care. But those days are really gone. So at this point, the acute care environment is so complicated that and people are very sick when they're in the hospital for the most part, and they stay for short periods of time. So we need to have these people who are fully dedicated to the care of hospitalized patients, and they're in the hospital 24/7, 365 days a year. So I have been a hospitalist for all of my clinical career since my residency, and in some ways being a hospitalist is like being a public defender, in that the hospital assigns you a patient, and in other ways it's like being a general contractor. You have specialists that you need to kind of coordinate the care for a patient with. And as a general medicine hospitalist, I see in a community setting, I see a broad scope of kinds of problems.
Well, there's many efficiency benefits of having a hospitalist who's dedicated to that work. One of the downsides or critiques of the hospitalist movement is that it's perhaps not as good for the patient-doctor relationship. In the olden days, the primary care doctor would follow their patient in the hospital. And one of the things that's great about the Cambridge Health Alliance is that you've done such a good job to create systems of communication between the primary care clinicians and the hospitalists. I have not seen it done as well elsewhere. How have you been able to do that?
Well, I think one of the benefits there is that we really are an integrated care system. So all of our providers are employed by the system, and that includes ambulatory providers as well as inpatient providers. We certainly do see people who come into the emergency department and get admitted to the hospital who don't have a primary care provider within our system, but pretty close to maybe 3/4 of the patients that we see in the hospital have a primary care provider in our system. We're all on the same electronic medical record, and so that it's easy for us to share information in that way. And I think although we are conscious of all sorts of ways where the integration among the parts are not nearly as seamless as we would like them to be, we do have, I think, as integrated a system as we can possibly build, and that's been a huge priority for us.
Well, many of the listeners of the Healthy Skeptic MD podcast are lay individuals, and so I like to give a little advice. And one of them is, if you do find yourself in a hospital and being treated by a hospitalist who's not your primary care doctor, it is perfectly appropriate to remind the hospitalist that they can reach out to your primary care doctor and get those background details about your care. So, Maren, one other warm-up question for you. You recently transitioned to a new role as the Chief Quality Officer for the entire Cambridge Health Alliance system. I know you've been working in that space for a while, quality improvement, but now, as of, I think, a year and a half ago, you've been the Chief Quality Officer. Could you tell us a little bit about what you do in that role?
So as the Chief Quality Officer, I'm a part of the senior leadership team for the institution, which includes a Chief Nursing Officer and a Chief Medical Officer and a Chief Operations Officer and a Chief Financial Officer. And the way I think about it is that my job is sort of to be a doctor to the system, not exclusively to be a doctor to patients, although I still continue to do that as well. But by being a doctor to the system, what I mean is it's my job to notice and to diagnose problems in the way that the system is functioning and the way the system is actually working to produce good health outcomes for patients. And then it's also my job, in the same way that it's my job as a doctor, to treat problems that I identify. It's my job as the Chief Quality Officer to sort of work together with others to try to fix the problems that I notice. So I run a department, quality and safety department, and we have 3 kind of basic functions. One is related to data, which is about how we measure how well we're doing related to providing good care. And that includes getting data from patients. We survey patients, we ask people how their experience was, what they think we could do better. And then try to figure out how to help the institution use all of that data and turn it into information so that we can actually use it to improve. The second thing that we do is that we are the engine of learning from our mistakes. So that means when something goes wrong, when somebody gets hurt in our care, when somebody develops an infection because of something that we did, When we do an x-ray on the wrong limb, it's my job to harvest all of those mistakes and then analyze them and learn from them and give them back to the system so that we can put corrections in place so that it doesn't happen again. And then the third function is really related to performance improvement, which you might consider sort of applying the science of systems improvement to the institution. It turns out that in many industries, people have been experimenting with how do you really change a system and how do you change a system efficiently and effectively.
So I think when many of us think about a quality officer, we think about very technical things like, did the antibiotics were they given when they were supposed to, or was there an error administering the medication, or whatever it may be. But one of your areas of interest and expertise is the communication between clinicians and patients. What isn't working well across the board between doctor-patient communication right now?
Well, you can talk to anybody who's had an experience in the healthcare system as a patient or as the family member of a patient in the last month and generate your own list of what's not working well. I think this is it's a universal experience that we have when we engage the healthcare system. Many things go very well, and many things don't. So all the things that can go wrong in ordinary human communication can go wrong in patient health professional communication. There's listening failures and there's talking failures. We sometimes don't ask the right questions. We don't share the right stories. We don't explain things clearly. All the things that can go wrong in human communication go wrong in patient health professional communication. But there are some specific, I think, ways in which the communication matters in the healthcare setting differently. One is that there's an expertise mismatch between the health professional and the patient. They're high stakes encounters, and when you come into the health system as a patient, you're vulnerable, you're scared, you're sometimes nauseated and in pain. That creates its own kind of communication barriers. There's a tremendous amount of diversity among people that interact in the healthcare system. And, fundamentally, our work to improve health for our patients, the most important, most essential tool that we have in our toolbox is communication.
So as I mentioned before, Maren was my supervising physician when I was in my medical training. And one thing I really admire, and I remember sitting on rounds with patients about how you were able to really put the patient in the center of the conversation and then bring in a very artful way, the technical knowledge to help guide the patient to the correct, or I shouldn't say correct decision, to the decision that best aligned with the patient's goals. And as an aside, I remember actually you were an English teacher before you went into medical school. And I always thought that maybe that had something to do with the way you were able to do that. But that actually that style contrasts with the traditional model where the doctor comes in and says, this is the way we're going to do it, and is very authoritative. What's wrong with the traditional model of thinking?
Well, thanks for that lovely compliment, Mike. It's really, I think, a great privilege to be in an environment where you have learners watching you, and to be able to see yourself through your learner's eyes is a really lovely thing. And so to think that you noticed that about the way that I practice medicine is a real gift, and I appreciate that. So thank you.
What grade did you teach in English? That's the one thing I can't
was
remember.
A high school English teacher.
High school English teacher.
Yeah, in Chicago. Yeah, and I actually do think that that does probably inform my way of thinking about the work of doctoring. Not only do I see my work as teaching not only learners, but also teaching patients and teaching family members, and it's a big part of my sense of what it means to be a doctor. But I think it also is important that I was an English teacher, because as you suggest, the traditional language of that interaction between a doctor and a patient is that the doctor is taking a history. And of course, what's happening there is that the patient is giving a history as much as the patient is taking it. It's an interaction. I see my job when I'm doing that kind of basic core work of doctoring as asking questions that help the patient tell the story. I think that what's often wrong with that traditional model where the doctor is sort of an authoritarian communicator, both taking the history and then making a plan and prescribing a set of actions, is that it doesn't work it doesn't work very consistently. In part, I think doctors loom very large in their own imagination. We see ourselves as kind of the protagonist of that encounter quite a bit, and it's quite easy, I think, for us to be proud of what we do in that encounter, of sort of making the diagnosis and then solving the problem, because ultimately, the patient is a person with agency who will make their own decisions. I have a son with asthma who doesn't take his medications the way his doctor thinks that he does. He has an asthma action plan that was written out by the doctor, and I'm sure the doctor felt good about having thoroughly described what should happen. But he's 16 and he does what he does. And his asthma is pretty well controlled. He can, he's a competitive rock climber and it doesn't seem to get in his way, but he's definitely making decisions about what he's going to do and how he's going to do it and when he's going to do it. And everybody does, because we engage, as human beings. It's a little bit of magical thinking that if we say it, it will be so. And if we prescribe it, it will be done. And in actual fact, of course, the world is much more complicated than that.
Well, I completely agree with you that it's the problem with the traditional model is quite simply it doesn't work. And I can say on the days when I don't spend the time to really engage the patient and come to a mutually agreed upon care plan, and I just say what I want to have happen, the chances it's going to actually happen that way are much lower. And I actually had last week on this, the last episode on the Healthy Skeptic MD, Dr. Elliot Fisher, who talked about something called shared decision-making and preference-sensitive care, meaning that there's not always a right or wrong way to do things, that there really are some options and reasonable people would take different approaches, and you want to come to the approach that best aligns with your goals, and many times patients will choose the less expensive or less aggressive or less invasive route. So he was really coming at it from a cost of care angle and utilization angle, but it also gets patients the care that's probably best for their specific scenario. Now, you've written about something called coproduction, which is taking that concept of shared decision-making even to the next level. Could you tell us a little bit about what coproduction is?
Sure. So I have to credit my dad for that term. He and I actually share an interest in health systems improvement, and he has been a mentor for me for many years. He's a pediatrician by training. And he and I, with a couple of other colleagues, wrote an article on the idea of co-production back in, I think it was 2015. It was a while ago now.
I'll put the article up on my website, so if you want to check it out, you can.
Great, thanks for that. In health professional circles, we've talked about the importance of patient-centered care for a long time. And there's a recognition that good care is patient-centered care and is respectful of patients and elicits patients' preferences and invites patients to participate in the work of producing good care. And I think this term co-production kind of participates in that same space of patient-centered care. For me, what's different is this recognition that it's not so much about the difference between good care and bad care. It's just a recognition that all health outcomes are inevitably co-produced. They're not actually being made or produced or manufactured by health professionals in a health system and then, sold to patients. We can't do that because we're talking about outcomes that are lived in the bodies of our patients. So we can't make them any more than in an education setting. Teachers don't make learning; they work with students to make learning. But it doesn't matter how good the lecture is if the student isn't listening. The student brings a whole bunch into the actual learning encounter with their curiosity and their energy. And so the learning that is produced is inevitably co-produced by the teacher and the student. And the same is true of healthcare, that health professionals, no matter how smart they are, no matter how good they are, no matter how much they care, no matter how sensitive they are or aren't to people's preferences, no matter how hard they work, they can't make health for other people. So health outcomes are always co-produced. And that's sort of the idea in the article, is that we drew a little picture of this, that at the center you have this relationship between a patient and a health professional, and somehow that relationship produces some kind of health outcome.
I remember reading your article, and it was a new concept to me, co-production. I did find it very useful in thinking how I engage with patients. And I do think it really highlights the contrast between a service, production versus a widget. If you're making a widget, it really is what you as an individual are producing. I was going to ask you, and please finish the thought you were about to say, but about whether other service industries have used this concept of co-production.
Yeah, for sure. And I do think that it is helpful to contrast the difference between making goods and making services. So if you are a car manufacturer, you can get advice from the market. You could ask customers what they care about in a car, and you can design a car such that it has airbags and that it has a good sound system and that it's white and not green, and you can actually get preferences from your potential consumers and build them into the design of your car. But the car can actually be manufactured without any input from customers, and that's just not possible in healthcare. You can't produce a health service or an education service without the active engagement of the, in this case, patient or the user of the service in some way. And that idea is actually what was first described by economists as they were trying to understand the work of measuring productivity in the service economy. And so somebody like Elinor Ostrom in the 60s, or Victor Fuchs in the healthcare system wrote about this. Elinor Ostrom actually won a Nobel Prize for it, for observations like police don't create public safety. They have to co-produce public safety with the neighborhoods that they are serving. So it's this notion that sort of fundamental to certain sectors of the economy, we have this necessary, obligate co-production. Right.
It strikes me as you say that with all the discussion about public safety right now, it may be worth going back to some of those concepts.
Yes.
to help guide reform.
Yeah. No, I think you're absolutely right. But I think we see this in other sectors of the economy a lot. Right now, I see this idea of co-production as an engine of innovation in several sectors, where we're playing in some ways with the boundaries around what's the job of the professional and what's the job of the consumer or the user. So, for example, we pump our own gas, we check ourselves in at the airport, we check ourselves out at the grocery store. These are places where we're kind of playing with that boundary around how do we push the responsibility to the consumer, to the user, sometimes for better efficiency, sometimes for lower cost, sometimes to allow customization. In some ways, a cake mix is an idea of co-production. It's not going to the bakery and having somebody bake a cake for you, but neither is it baking it from scratch. The new model fast food, mass customization fast food, where you go to a you go to a counter and you choose your grain and you choose your protein and you choose your vegetables and you choose your sauce. It's in some ways a co-production innovation. It's about, like, can we give the customer a little bit more opportunity to customize and use their preferences to produce something unique that they want.
Yeah, as you describe that, it's making me think that there clearly are some companies that are doing a good job of this co-production. Maybe some of the food, fast food options, I found to be very helpful. But there's also situations where I can see that it hasn't gone well, and tech is a big place where that comes up. There's all these apps, and you get frustrated, and and I think a lot of it is if it's not clear and simple and concise, it can be hard to engage the recipient. One thing you mentioned that really caught my attention is, in order to produce a healthcare service, you really need the patient. You can't produce a health outcome without the patient's engagement. So what about the situation where a patient bumps it back to you? You say, well, here's the options and we can consider it. And the patient says, well, you're the doctor. You tell me what to do. Is that someone who can't be engaged in their care?
Well, certainly, I think I've heard the same thing from patients who don't want to make a healthcare decision. I think part of the idea of this co-production kind of frame is that you're recognizing, again, that these health outcomes are inevitably co-produced, and you're probably going to get better health outcomes if the quality of the partnership is strong. But that being said, part of your job as a partner in this co-productive partnership is to understand how much people feel capable of doing, how much they want to assume authority for decision making. I also think it's true that there's a spectrum. Not every healthcare interaction is the same. So if you're hit by a car and brought unconscious in an ambulance to an emergency department, you have no agency. You are not co-producing your health outcomes at that point. You are completely in the hands of the emergency department personnel. And if you end up in the operating room and they leave a sponge in your belly, that is totally on them because you were unconscious, right? But as soon as you come to in the PACU, you start to have a little bit of agency around your health outcomes. You have pain. You ask for pain medication, and you get it or you don't get it in the way that you want it, and you begin to become sort of a player again in that partnership.
Well, the only insights I would add to that are, one, if you do have a patient who's not engaging, at least at the moment in the care, that just is a clue to you that your job is different. So I'm doing a homeless healthcare program right now and addressing a lot of patients who have substance use challenges. And we talk about, they start out in the pre-contemplative or contemplative stage about making changes, and maybe we're not ready to co-produce an intervention that's going to address the situation right away, but it's about sort of leading them and helping them get to the point where they're able to co-produce, and you just have to shift your mindset. The second thing is, sometimes when patients bounce the question back to you, you tell me what to do. Once you say it, actually, they start to engage and co-produce with you. So I can't tell you how many times I'll say, well, if it were me, I probably would get the surgery. And then the patient said, but wait, I thought you just said I had an option of not doing the surgery. And actually they do have opinions, and, in some ways they just want to hear what you would do. And it helps them come to a decision that you can implement together.
Absolutely. And I also think that we have such a long history of kind of authoritarian relationships in healthcare that it does sometimes take a little while for somebody to believe they have the right to make a decision, or at least to tell you what they think they want. So, as I said, I'm a hospitalist, and so for many years, I did think I was the person who was best equipped to decide whether somebody should come into the hospital and when it was time for them to be discharged. And as I've been thinking more and more about this kind of the idea of co-production, I realized that I only have half of the information. And so I will often say to somebody, do you think you're ready to go home? And sometimes people are it's an easy answer, and they say yes or they say absolutely not. And sometimes they'll say, well, you're the doctor, you tell me. And I can give it back to them, and I can say, well, here are the things I can see. I can see your white blood count, I can see your blood pressure, I can see your fever, but I can't know how you actually feel, and I don't know exactly what you're going home to and how much support you're going to have at home. And when I lay it out like that, I invite them to tell me what they actually think, but sometimes I actually need to give people permission to tell me what they think.
Well, that's one thing that's always frustrated me about the health plan guidelines. You need to meet these criteria to remain an inpatient, but that's only half the information. You don't know what the patient could be discharged to, and that has to factor into the decision about whether a discharge is appropriate or not. So you're the chief quality officer at Cambridge Health Alliance, and one thing we doctors have a love-hate relationship is with quality metrics. And if patients are so important in co-producing, how can I as a doctor be held accountable to health outcomes that are only half dependent on my actions? What's your response to that?
Yeah, no, I think it's right. I mean, I think that's a fair criticism, and I do think that there's been a lot of interest in experimenting with pay-for-performance kinds of strategies. So if you can get your population as a primary care provider, if you can get your population of diabetics to get their blood sugar more tightly controlled, then we will give you a financial bonus, right? And I think obviously what's wrong with that model is that you're paying me for outcomes that are living in the bodies of other people. So there's a very complicated, I think, moral dilemma in a lot of ways there. And it's also, it underestimates the importance of the choices that patients make in these outcomes. One of my favorite studies is an actual randomized controlled trial of that idea. It came out of Kevin Volp's lab in Pennsylvania, where they actually took partnerships, providers and patients, and randomized them into 3 groups. The goal was to decrease cholesterol levels. And in one group, they just paid the providers if the patient's cholesterol levels got lowered. In one group, they just paid the patients if their cholesterol got lowered. And in the other group, they paid them both. And the only group that got statistically significant lowering of cholesterol was the group in which they paid them both. A sort of a nice little randomized controlled trial of co-production.
That is a fascinating finding, and it actually validates, an evolution of my thinking. I used to, when I first came out of training, think that incentives made a lot of sense to get doctors to, be more accountable for their outcomes, and I've shifted away from that. But that's a very interesting study that I hadn't designed, that I hadn't thought of sort of co-incentivizing the patient and the clinician.
It does though galvanize sometimes when there's pay for performance stakes. It can galvanize the provider and help people understand what matters most or what we should be focused on. And if you recognize that the only way you're going to get good outcomes is if you have a good partnership, it can inspire you to think creatively about how to actually be a better partner.
Yep, and I imagine that financial incentives aren't the only types of incentives you could use. You could get creative about incentives that really would make a difference for everybody. Well, this has been a really enlightening discussion, Maren. I can see the English teacher in you coming out, so it's great to hear it. My final question for you is: there's been a big shift in the world over the last 21 months, the pandemic, and I think it's changed a lot of our perspectives on things. How has the pandemic changed your view of communication between clinicians and patients?
I think there are two big things with respect to co-production. One is, although we knew that there were health disparities between groups, and we look at our own data to try to look at whether we're getting better outcomes for people who are English speakers and non-English speakers, and people who are white and Latinx and people who identify as Black. We have never seen health disparities like we saw in our own data in the COVID pandemic, and so I think it has unroofed kind of the abscess of inequity and health disparities, and that matters a lot as we think about what kind of partners can we be if we're co-producing outcomes when we have this legacy of discrimination and mistrust and lack of respect that compromise our ability to partner effectively with everybody.
Certainly, where I've provided care, been a doctor, these disparities have, as you said, really sadly blossomed in a bad way. During the pandemic. One question that's raised for me related to communication is when you have clinicians of different backgrounds as patients. Do you see that as necessarily a barrier when people are coming from different backgrounds? Between the doctor-patient relationship? You mean when people discordant backgrounds?
Yeah, when a partnership is trying to partner across a cultural gap. I mean, I think fundamentally we have more in common as human beings as we have that separate us. But I do think that this requires us to enter into these partnerships with more curiosity, more humility about what we don't know, more respect for the complexity of some of the dynamics that shape that relational trust that is so important to these partnerships. So I think it requires that we enter into these relationships across these barriers with a more self-awareness and more humility.
Well, I have to say, I'm happy you said that. I've often felt that I can be as good a doctor it doesn't matter what your background is, but the data have at times suggested otherwise.
There's so many ways in which we are different from one another, and so being able to connect across what we have in common as human beings it's always going to be fundamental, which is not to say we shouldn't have more diversity in healthcare professionals and we shouldn't try to build a healthcare workforce that is as broadly diverse in every possible way as the patients that we're caring for.
Well, we probably could have an entire podcast dedicated to this topic alone, but it's an interesting way to end the discussion today. So thank you very much for joining me today, Dr. Maren Batalden from the Cambridge Health Alliance, and thanks for joining the Healthy Skeptic MD. If you enjoyed what you heard today, please do search and subscribe to the Healthy Skeptic MD wherever you listen to podcasts. Pass it on to friends, family, and others who might be interested. Consider leaving a review if you have a chance, and we'll pick it up again in a couple weeks. Thanks again, Maren.
Thanks so much, Mike. It was a great privilege.